my name is Watts, and for my capstone project, I'm going to be discussing the use of rotoprone therapy in patients with acute respiratory distress syndrome, or ARDS. For my practicum experience, I followed a nurse at the University of Kentucky Medicine ICU while she cared for a patient in the rotoprone therapy bed. My learning goals for this practicum experience were to understand the indications and use of rotoprone therapy, to learn how rotoprone therapy works and how it improves patient outcomes, and to discover how nursing care is affected by the use of prone and rotoprone therapy. The indication for rotoprone therapy is acute respiratory distress syndrome, or ARDS. And ARDS is a lung injury that causes an overwhelming inflammatory response, resulting in severe lung dysfunction. There are some specific inclusion criteria for a lung injury to be classified as ARDS. It includes acute onset bilateral infiltrates on a chest x-ray, PaO2, FiO2 ratio of less than 300, with less than 100 being classified as severe ARDS, and there being no evidence of left atrial hypertension. The most common cause of ARDS is pneumonia, and some other direct causes are aspiration, pulmonary contusion, inhalation injuries, near drownings, and fat emboli. Some indirect causes are sepsis, severe trauma with shock, pancreatitis, and drug overdose. And all of these criteria or causes are seen in the Medicine ICU at UK. So there's some specific treatment for ARDS patients, and this treatment is in the literature is proven to be most effective in taking care of ARDS patients, and this is also the treatment that is utilized by the Medicine ICU. And I mean, the first way to treat ARDS is to determine the underlying cause and treat that. The other very important part of treating an ARDS patient is that they need to be mechanically ventilated, but they have to be mechanically ventilated in a very specific way. And they need to have their plateau pressures be less than 30, because having very high plateau pressures can cause barotrauma to the lung. And these patients' lungs are already having a lot of issues and very damaged, and so if you cause further damage, it can really set these patients back. You also need to maintain the patient's PaO2 between 55 and 80, and this can be done by changing the PEEP on the ventilator. These patients are typically on pretty high PEEP, and you can also change their volumes. These patients, you want to normalize their pH between 7.3 and 7.45, and this can be done by changing their respiratory rates. ARDS patients are very uncomfortable ventilator settings, and so they almost always need sedation and pain management. And sometimes that isn't even enough for these patients, and they need to be paralyzed in order to decrease their oxygen demands. And these patients need to be managed in an ICU environment. Some additional treatment options for severe ARDS patients include prone therapy, nitric oxide, and extracorporeal membrane oxygenation. And the University of Kentucky does implement all of these therapies. However, the Medicine ICU, they utilize prone therapy through the use of the rotoprone bed. Prone therapy is when a patient is positioned in the face down position on their stomach and mechanically ventilated. This can help to improve oxygenation in ARDS patients by increasing aeration of the posterior lung and reducing compression on the lungs, particularly from the heart. Some studies have shown that prone therapy can help to decrease mortality in ARDS patients. However, the findings are pretty mixed. There are some considerations that need to be made when a patient is going to be put into the prone position, and these patients are in an ICU environment. They have a lot of monitoring devices on them. They have a lot of invasive lines, and so turning these patients can be extremely difficult. A lot of staff is needed to rotate these patients into the prone position, and so these can be issues that prevent a patient from being moved into the prone position. The rotaprone therapy system was developed to help move patients into the prone position more effectively. And it allows for ARDS patients to be rotated into prone in an automated way. The bed also allows for side-to-side rotation when supine and when in the prone position. However, some ARDS patients have contraindications that prevent them from being able to be put into the prone position or be in the rotaprone bed. Unstable hemodynamics will not, you can't prone a patient if they're too unstable to be turned. Unstable fractures, cervical and skeletal traction, and uncontrolled intracranial pressures. The rotoprone bed also requires that a patient be a certain size in order to be used safely. If a patient is too large, including too tall, too short, too heavy, or too light, they can't use the bed safely because they simply won't fit into it in a safe way. This is an image of the rotoprone bed. At the top of the bed, the head of the bed, you can see the guide for all invasive lines. There's also a holder for the ET tube. This image is missing the faceplate that goes over the patient's face to hold their head safely in the bed when in the prone position. You can see all of the packings, which are the blue padding that the patient must be put into the bed with, and then these safety belts which keep the patient secure when in the prone position. This image shows in the middle of the image you can see the patient in the prone position with the back hatches open. And these hatches should be opened anytime the patient is in the prone position in order to allow nursing care to be performed, in order to allow for full lung expansion and decrease skin breakdown. You can also see the controls, which are at the end of the bed, and the lock pin, which is right here. There's some specific nursing considerations when a patient is placed into the rotoprone therapy bed. Skin breakdown is the biggest concern. These patients are packed very, very tightly into these beds, and they're kept in them for quite a while. So any bony prominences can get skin breakdown. So all of these areas should be padded prior to putting a patient into this bed. Line management is also very important. These patients typically have a lot of monitoring and invasive lines that you don't want to be pulled when the patient is being rotated. Their mechanical ventilator and ET tube also need to be watched whenever a patient is being turned in these beds. And then you need to make sure the lock pin is always in place. And then any hatches on the back of the bed must be shut and locked prior to returning a patient to supine. In order to prepare a patient to be placed into the rotoprone therapy bed, you need to lubricate their eyes, tape their eyes shut, pad all of their bony prominences with Mepalexes or another similar device, add extensions to all of their tubing, and you want to remove their gown and any sheets, and they are not placed with any bedding into these beds. Only the packing is utilized in order to prevent skin breakdown. And then all of the packing needs to be placed appropriately and secured in order to keep these patients safe when they are rotated. When a patient is rotated into the prone position, you need a minimum of 2 nurses and 1 respiratory therapist. And one of the nurses is going to be at the head of the bed, manning the lines. The respiratory therapist will be watching the ET tube and ventilator, and then the second nurse would be at the foot of the bed manning the controls. You want to turn the patient towards the ventilator, And then once the patient is in the prone position, you want to put them into reverse Trendelenburg in order to help prevent facial edema. Open the back hatches once the patient is in prone position in order to allow for full lung expansion and prevent skin breakdown. And then you want the patient to be in the prone position for at least 18 hours a day. And studies have proven that that is most effective, and that is also the therapy that the MICU utilizes at UK. In my experience during my practicum, the University of Kentucky Medicine ICU follows the literature on ventilator settings and the use of the rotoprone therapy bed. They follow this criteria, tailoring it to each specific patient, but they do follow the criteria as indicated in the literature. This experience was very interesting to me. I work in a different area of the hospital where we also take care of ARDS patients, but we utilize very different therapy. And so it was eye-opening to me to see some of the therapy that I've never used and how it can benefit these patients. These are some references I used for this presentation. Thank you very much.